Welcome to our conference session titled Living with MDS. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you're participating online, please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit your question or comment, type your question in the Q&A text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. Submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your personal health care. Our specialist today is Catherine Lai. Dr. Lai is an associate professor and physician leader of the Leukemia Clinical Research Unit at the University of Pennsylvania's Center for Advanced Medicine. She is board certified in hematology, oncology, and internal medicine. She specializes in detecting, monitoring, and treating acute leukemias and myeloid malignancies in adults. Previously at the National Institutes of Health and MedStar Georgetown University Hospital, she focused on clinical trials in acute leukemia. Dr. Lai's research focuses on novel therapeutics, designing and conducting clinical trials and health outcomes for leukemia and myeloid malignancy patients. Her goal is to provide excellent care for communicating effectively and educating patients in a collaborative environment. With that said, it's my pleasure to welcome Dr. Lai.
Thank you. Hi, good morning, everybody. Can you hear me okay? Okay. So I just wanted to first start off by saying thank you to the AAMDS Foundation for having me and Dr. Thoda as well. It's a pleasure to be here. My goal today is to talk to everybody about how we manage MDS. And with that, I really stress the importance of patients and families being informed so that you can have an informed discussion with your physician and your care team. These are my disclosures. Okay, so here's our roadmap for today. We'll talk about what is MDS, why me, how does this change my life, when should I be treated, what are the treatment options, and newer treatments in MDS. So again, just really the take-home points for today are really just to be an informed patient. Some of the things I'll be talking about will be something called an IPSS-R risk score or risk group, treatment options, give you information to think about your treatment goals in terms of both the short and long-term side effects, also resources and caregiver support. So let's start with the basics just to put everybody on the same page. So what is myelodysplastic syndrome? So if we break it down, myelo meaning marrow, dysplasia meaning abnormal growth or development of tissues or cells, and syndrome is a pattern of signs and symptoms and behaviors that happen. So MDS is a blood cancer where you have these abnormal cells in the bone marrow that don't do what they're supposed to do and cause this constellation of symptoms. So I give this analogy to most of my patients when I first see them. If you think of your bone marrow as having three different functions, and those three different functions are the immune system, your white blood cells, your red blood cells or your hemoglobin, and your platelets. I think of these as like three different types of flowers in a flower garden. And what happens in MDS is that you have weeds that have invaded your flower garden. So let's talk about the epidemiology of it. So the median age is in the mid 70s, so 76. The incidence is between 5 to 13 per 100,000 people. For patients who are over 65, that number increases significantly. In total, there's between 60 to 170,000 cases in the US. The reason why that number is so broad is because it can sometimes be hard to capture this data. And then in general, just the cost burden. So something to think about is really, it comes a lot from transfusion requirements. And so there's a significantly higher healthcare cost associated with that. So also something to keep in mind when we're talking about treatment as well. And so then here's just a visual representation. This is data taken from the SEER database, so all within the United States. And as you can see, irrespective of race or ethnicity, that there's an exponential increase after the age of 65 or so in terms of the incidence of MDS. So what happens to patients with MDS in general? So this is if you were to take 100 patients represented in the US, we'll start at the bottom here. About a third of MDS patients have a low risk MDS and it doesn't cause them problems and they're monitored closely and they typically die of unrelated causes. You have about a quarter of patients in this dark purple here where those will progress to AML. I'll get into that. Those are the higher risk patients. Then you have other patients here in the taupe color where they have issues with anemia-related complications. The larger complication tends to be infection. So about 20 of those 100 will have infectious complications. Since MDS causes your counts to be low, so you typically have issues with bleeding or bruising. So there are patients who have that as well, 12 out of the 100. In general, about 6 of the 100 are able to undergo allotransplant. Allotransplant is the only potential cure for MDS. However, it's not without its own complications, especially in an older patient population. So what are the risk factors associated with MDS? So the majority of them are required because we're focusing on adults. So as we get older, we acquire different mutations which contribute to MDS. I say that as we get older, we acquire wisdom, but unfortunately also with that unfortunately comes some mutations. If those mutations come together in the right way, that's what causes MDS. In terms of mutation exposure, this isn't an issue now, but when we think of exposure, we talk about chemo and or radiation, but then we all talk about major chemical exposure. And this is on the order of things like Chernobyl and Hiroshima, which aren't issues anymore, but there are people around who have had those exposures, or if there's been significant benzene exposure, but the everyday, day-to-day household chemical exposure is not a risk. There are other hematologic disorders such as aplastic anemia and PNH, which can also contribute, which that's a small subset. And then there is this subset of inherited predispositions, but that's more commonly seen in children and young adults. So then let's go back. So again, what is bone marrow? So bone marrow is in the inside of the bone, and it is responsible for these 3 main functions: your red blood cells, your white blood cells, which again, protect against different parts of the immune system, and your platelets, which prevent bleeding. So when we look at what happens normally, when we look at our stem cell, we have the stem cell at the top. And again, think of it as it divides into 2 main groups. Your lymphoid, the lymphoid side, which mostly fights against types of viral infections. Whereas your myeloid side is responsible for those 3 things that I mentioned, your immune system, your blood cells, and your platelets. And specifically, it's the neutrophils that we worry about when patients have MDS, and those are low, and they're at risk for bacterial infections. Which is why a lot of the time when your counts are low, we instruct patients to go to the emergency room if their temperature is over 100.4, if your neutrophil count is low. And so again, in MDS, this is what happens, is that you're not getting normal production of these cell lines. So because we're hematologists, we like to look at blood under the microscope. And so this is just to show you some of the things that we see when we're looking at the blood that you're giving us. So on the left here, you can see a normal blood smear. And here you can see these big ones are normal white blood cells. What you can see is all these other smaller circles. These are all red blood cells that they're supposed to be there. And these tiny ones are platelets. And what happens in MDS is it looks a lot more chaotic and it's filled with these other abnormal cells that have gone awry. When we talk about MDS on a kind of microscopic level, there are different things that contribute to your risk group. And so one of them are chromosomal abnormalities. So the word cytogenetics would come up when you're talking to your physician, and what that means, whether or not they're normal cytogenetics or abnormal cytogenetics. So it would be a good question to ask. And then I mentioned the idea of these mutations. So in this diagram here, what happens is each color represents a different mutation. And so as we acquire mutations, if those mutations are small, so think of this as a timeline in terms of going from shorter to longer duration from left to right. And so what happens here is that if you have mutations and the percentage of them is small, then those by themselves, whether or not there's one or multiple of them, doesn't in itself cause MDS. But if those mutations grow, represented by the widening of the color of the picture here, is that it's the combination of these mutations and the percentage at which that mutation occurs that then causes MDS. And then in the third of patients that progress to AML, patients acquire additional mutations that contribute to that. And we call that clonal evolution. So what happens when you have MDS? What do these patients look like? So this picture on the right is a picture on the left is somebody who has MDS. On the right is a hand with somebody who does not. And what you're seeing here is pallor. So because the blood level is low, you're not getting as much oxygen to the tissues. And so therefore the color is decreased. That's why the hands are pale and why patients often appear more pale. Here, this other picture is an extremity or an arm with bruising because the platelet count is low. So patients are at more risk of easy bruising. Some patients may have no symptoms. If you catch MDS very early and your counts are only mildly decreased, but not in any dangerous range, you might have no symptoms. Commonly, the most common symptom is fatigue. So because the blood counts are low and because the immune system is weak, that causes a fatigue, as well as weakness. And then on the lab abnormalities, you would see your blood counts being low with leukopenia, anemia, and thrombocytopenia. So how do we diagnose MDS? So I just have this cartoon up saying that I would be a healthy person if you'd stop finding things wrong with me. So I'm sure there are many people in the audience who have had a bone marrow biopsy. And for those who haven't, patients lay on their stomach or they lay on their side, and you have a needle that's inserted into the bone. Again, this bone marrow is in the center of the bone. The different parts, so there's two different parts to the bone marrow biopsy in which you get the liquid part of it, which is called the bone marrow aspirate. And then we also take a little piece of the bone, which is called the core biopsy. And we use these to look at different things. Which I'll get into and is important for your risk group. So then what do we do with the sample? Okay, so here you can see, so the morphology. So this is where we take it and we look at both the aspirate and the piece of the bone under the microscope. And so this is what we do in collaboration with our pathologist. So when we're doing that, typically your pathology report is describing what is seen under the microscope. Okay, and then there are different things that we do with the liquid portion, the aspirate, things called cytogenetics, flow cytometry, and FISH testing. Okay, so what are these things? So cytogenetics are where we take that aspirate and we look for different mutations that might have caused MDS. With FISH testing, it's similar, or we're looking for a specific abnormality. Say we know that you have a deletion, or we're looking for a deletion 5 or a monosomy 7. Then we can look for these specific abnormalities. And then flow cytometry is something where we take the cells and we put them, think of it as single file going through a traffic lane. And based on each cell has different color flags. So think of it as different color cars. And based on the pattern of the cars in that single file line tells us that this is, more an MDS or more an AML or a different type of disease. Okay, so what does really all that mean? Because that's a lot of stuff. So let's break it down again. Okay, so if we start with the big picture, so we think about, we're looking at the microscope, we're looking at what the aspirate and the bone marrow looks like under the microscope. So think of this as you having a really cool telescope and you are looking into space and you can identify all the planets and you know where planet Earth is relative to the sun and the moon and the stars. So think of that as what happens when the pathologists look at the bone marrow and the aspirate under the microscope. They're trying to identify what's normal and what's abnormal and whether or not there's a presence of MDS there. So now we have a diagnosis of MDS, but we need to dig a little bit further. So what goes next? So the flow cytometry, where we're going single file through that traffic line, that's like zooming in a little bit further from Earth to the United States. And then when we do cytogenetics and FISH testing, where we're looking for those different mutations and abnormalities, that's like zooming in further into Washington, D.C. And then we have something else, which I haven't mentioned yet, called next generation sequencing, which is newer technology, which looks at even more mutations. And that's like zooming in even further from Washington, D.C. into the White House. So all of these in combination, we use all these tests. It forms our different layers and helps us understand the patient's MDS and their disease. So then what do we do with all this information? So we have all this information. And so then we take into consideration what the blood counts look like. So we're seeing if your anemia, your hemoglobin is low, if your neutrophil count is low, if your platelet count is low. Then we're taking into consideration what we see under the microscope. So are there abnormal cells? How many of them are there? And then those mutations and the cytogenetics that I was talking about. And then we also want to make sure that it's not something that your blood counts aren't low from something else, because there are some nutritional deficiencies like vitamin B, like B12 and folate, which can also mimic what the blood counts look like in MDS, but it's actually not causing MDS. So we want to also always make sure that there's not a virus or some nutritional deficiency that's causing MDS, since that can be treated. So just for everybody's awareness, so the classification for MDS was just updated within the last month. Prior to that, it was updated in 2017. Just to throw some more letters out there, there are now 3 different classifications. So the landscape is getting more complicated. So we have what's called the WHO, the World Health Organization. We have now an international consensus consortium as well. And we also have kind of European Leukemia Network. So all this to say is I know this is a large table. It's mostly here for your reference, but MDS is now classified into, do you have a genetic abnormality versus do you have abnormal cells under the microscope? So there are now different ways in which we can determine whether or not you have MDS. And then the other consideration under all of that is, do you have these funny looking cells called blasts? If the blasts are less than 20%, we consider that MDS. When it's more than 20%, we then say that that's transformed into acute leukemia. So then again, this IPSSR, this is something I want you for the patients and their caregivers to bring up when you're talking to your physicians about what your score is, because then that helps determine treatment. So again, we take into consideration your hemoglobin, your platelets, and your neutrophil count. And then we look at how many of those funny looking cells, the blasts we see under the microscope, as well as what your cytogenetics look like. It gives us a score. And then that gives us a sense of how long a patient might live, as well as whether or not they have a high likelihood of transforming to MDS or not. Now, the caveat to this is that this score was created in the 1980s, and it was prior to us as physicians having treatment for MDS. So I would say I would take this information with a grain of salt, because median numbers mean that half the patients live longer and half the patients live shorter. But I would probably say that in general, these numbers are longer because we now have treatments for MDS. There's also in the last few years a different risk score that's not widely used yet, but just to put that information out there so you're aware of it, it's called an IPSSM, which the M stands for mutations. And I've talked about the different mutations and that occurs on your next generation sequencing panel. And though the mutations aren't currently incorporated into the IPSSR. And so now there's a calculator where you can look at the different mutations you have and add this into the formula to see if that changes your risk. You don't have to remember the formula at all. They have calculators for that, so which are all publicly available and online, and I've listed them here. So if at any point you just want to go back and see what your IPSSR or M score is, you can do that here. Okay, so now I've talked about the score. What does the score mean? So again, it gives you an idea of what your median survival is. I don't like to give numbers because I think it's because there's no number that we ever give patients that is going to be good enough unless it's 100%, which is not guaranteed in anything. And again, there's so many different factors that go into these median numbers, comorbidities, how active patients are, how patients might respond to disease. So I say really the best sense of how a patient is going to do is more time, which I know is anxiety provoking. But if you're somebody who we're just watching your counts and you go for a few years, many years with your counts not changing, that is a better predictor of how you're going to do long-term than if your counts drop at a more rapid rate. So I know everybody asks their physicians about numbers, but again, I think it's their median numbers, meaning they only give us some information, but I wouldn't think about them in concrete values. So the risk groups are stratified into, think of it as a 5-point scale on 1 to 5. We have very low, low, intermediate, high, and very high. And again, based on this information, mostly done pre-treatment, if you're very low risk, the median survival is closer to 10 years versus if it's very high, it's less than 1 year. And then there's everything in between. And the patients who are very low risk do not have a high risk of transforming to AML. And the patients who have a high risk have a much higher chance. And in general, we say those in the high risk categories, it's about 30%. So now we know, for those who have information about different mutations and know about that, this is just, again, a table I've put together in terms of some of the high risk mutations, some of the ones that are neutral, and there's one mutation, the SF3B1, that we know is favorable. And the reason why I've grouped them into these different functional classifications is that hopefully in the future, we can then target these different functional categories so that we can target multiple mutations as opposed to just one for treatment purposes. What's also come out in the last decade is that we know that the number of mutations matter. So if you have more mutations, so these are survival curves. And what happens is this is overall leukemia-free survival on the left and risk of transformation on the right. And how I interpret these, if you were to look at these curves, is that you look at the 50th percentile, or 50% here, which is in the middle. And then you move horizontally across the curves to see how long patients go without risk of transformation. So here, in somebody who has more than 6 mutations, you can see that time frame is less than 10 months, compared to if we all go all the way out to if you have 0 to 1 mutation, the likelihood of progressing to leukemia goes out here to at 50% of those patients at 50 or 60 months will have progressed to leukemia. So the number is much lower. And then on this curve here, you can see it's just the same information presented a different way, but the incidence of AML transformation. So here, the steeper the curve, the more likely you are to transform. To summarize, it really just is saying that the number of mutations, the more mutations you have, the higher risk. So I would say the take home point being is that to ask your physician about your NGS panel, and then specifically about the number of mutations that you have. Within mutations and the low risk categories, these graphs are here showing that if you have low risk disease, now we know that even in the presence of mutations, that sometimes that can make you have poorer risk, which is why we've moved from the IPSS-R to the IPSS-M to help us better understand an individual person's disease so that we can be more targeted and more specific and treat patients individually as opposed to lumping them into a larger group. Okay, so can you do anything to change my prognosis? So I would like to say that we can take vitamins and eat differently and exercise differently, and that would change it. But unfortunately, it is predetermined. For the majority of patients who have developed MDS, there's nothing that you could have done differently. So I stress that to say that you shouldn't think about all your life activities to think about whether or not that might have caused my MDS or not. For the majority of patients, it's unfortunately just bad luck. We are starting to learn more information about inherited mutations, so more to come on that. So that might change in the future. But at the moment, I would say, for once you've developed MDS, you should try to be as active as possible is what will allow you to be possible. And that's just in general, people should exercise and try to eat healthy, but it's not going to change change your MDS in any way. So now I want to transition to factors to consider when you're looking at treatment. So things to bring up with your physician and things to think about before you get there are, what are your treatment goals? That's the biggest one. And if you don't know, I know that's also kind of a big thing to think about. If you don't know specifically about a goal, I think about how do you live your day-to-day life? Can you tell your care team what you like to do on a day-to-day basis? Is there a milestone that you want to go to? Somebody's wedding, somebody's birthday, somebody's graduation, and how important those things are to you. I think that it gives us a much better sense of what your goals are, and from there we can figure out how to get you to those time points. Then I think about controllable factors. So how much social support do you have? How frequently are you going to have to be coming back and forth to clinic? With prices of gas and people living far away, coming back and forth to the city isn't always realistic or feasible. And then there are uncontrollable factors such as age, comorbidity, and your risk status. So what are your treatment options? So when we talk about specific FDA approvals for MDS, there aren't that many of them, but we're working on them. The first three, azacitidine, decitabine, and decitabine, cetirizine, are those essentially all work the same, but they're just given in a different fashion. Lenalidomide is a pill specifically for patients with a 5q deletion who are low risk. And actually there's one here that I put luspatercept on here as well, which I have slides on it, but I just didn't put it on this slide here. What's commonly used in low risk MDS are what you've probably heard of as growth factors or immunosuppressive therapy or ion chelation treatments. Interestingly, these are all approved for other indications, but we use them commonly in MDS. So just, fact for you. When we talk about growth factors, names like Epogen or Procrit, Aranesp are drugs that increase your hemoglobin, so it would help with fatigue. Luspatercept is the newest FDA-approved drug that works in a different way that can also improve your blood level. Neupogen is commonly used if your immune system is weak in the setting of recurrent infections. So it's not commonly used, but is there in our armamentarium. Immunosuppressive therapies are specific for patients who what's called a hypocellular MDS. So it's a small percentage of patients. And iron chelation is used in patients who have had frequent blood transfusions, who have a lot of iron so iron is present in all blood transfusions. And the red blood cells, the blood only lives so long, but the iron stays around forever. And so if you get too many transfusions over a lifetime, we worry about that iron depositing in organs and making your organs not as stretchy, so not able to function as well. And so we want to give iron chelation agents to bind that iron and let the body get rid of it. So the reason why I've focused a lot on the risk group is because we use these algorithms to help us determine what our treatment options are. So essentially you go into these baskets of being lower risk and asymptomatic versus low risk versus high risk. So in patients who are asymptomatic and they're low risk, these are often the patients who have mildly low blood counts. They're a little bit tired, but don't need transfusions. We just watch these patients. They come, back and forth to their hematologist or oncologist, typically every 3 to 6 months, depending on the patient. And we just look at the rate of the trend of the blood counts. And we intervene if and when it becomes appropriate. For the patients with low risk MDS, but have their blood counts low, depending on which blood count is low, whether or not it's most often it's your hemoglobin, we can give those medications that I mentioned. So the things like Aranesp and Procrit, if your blood level is low, and something called your EPO level is also low. Again, if you have the specific 5q deletion, we can use that chemo pill called lenalidomide. Also, this is an older chart here, but luspatercept is also on this lower risk disease. So all these drugs help make patients feel better. It doesn't change the trajectory of the MDS. It doesn't put the MDS into remission. It's just helping improve quality of life and symptoms. And in higher risk MDS, these are the ones that we worry about the highest risk for transformation to acute leukemia. And so when you're high risk disease, that's when you're talking about getting more intensive chemotherapy and whether or not you would do something like a bone marrow transplant. So let's talk about low risk treatment first. So we have watch and wait, we have growth factors, we have lenalidomide, immunosuppressive therapies, and then clinical trials. So again, watch and wait. We know that treatment isn't always better, and that if treatment is not going to prevent your MDS from transforming to AML because you're in that low risk group, and it's only going to help your symptoms, there are side effects with every drug. And so we have to weigh the risks and benefits of side effects. And so I never want to give a patient more side effects than they're currently having. So in an appropriate patient population, we can just watch, which sometimes feels like you're not doing anything, but you're actually saving treatments for later on, which will then be helpful when you need them. So these are the names of growth factors. I'm putting them here so you're familiar with the names: Epogen, Procrit, Aranesp, Neupogen. So they're specifically in this category called erythropoiesis stimulating agents. They're given to patients who have symptomatic anemia. So we're talking about hemoglobins that are in either less than 7 or even in the 8 to 9 range. If your hemoglobin's already in the 10 to 11 range, the risk benefit isn't in a patient's favor. So it can either be for patients who have really low counts and haven't received a transfusion yet, or are already receiving transfusions, and it can bring their numbers up to a level where they no longer require transfusions. What happens is that you every patient in their bone marrow has a flag on it. We'll call it the EPO receptor. And that flag is low in MDS patient. There's not that many of them. And so by giving this medication, it's stimulating the body to make more of those flags so that the body can then make more blood. It can be given weekly. It can be given twice a week. Not twice a week, weekly or every other week, sometimes every 3 weeks or every month, depending on the patient's needs. So luspatercept is the most recently approved kind of agent in this category. It doesn't work. It works a little bit differently than EPO. Think of it as it being, if we call EPO a red flag, we're going to call this one a blue flag. And so it's in patients who have not responded to EPO, you can try luspatercept. When they looked at the original trial, it was specifically with patients who have something under the microscope called ring sideroblasts and with that SF3B1 mutation, but there's more data now coming out that's showing that there are other patients who might benefit from it. So I think it's definitely worth talking to your oncologist about it. If you've either been on an EPO stimulating agent and it's not working, or you have one of those mutations, or depending on how your MDS looks like under the bone marrow. This was the study, this was initially presented in 2018. So really, not that long ago, in the last 5 years, where they looked at luspatercept given it's an injection that's every 3 weeks compared to nothing, to placebo. And when it works, you continue it indefinitely as long as it's working. The main thing, that the primary endpoint is that patients became transfusion independent, so able to improve quality of life. And so when they look at that, they look at the improvement over 8 weeks. It doesn't happen right away. So if you do start these drugs, it's something to be mindful of, and that it can take a month. Sometimes it can take several months before you see an effect. So G-CSF or Neupogen, for me personally, I really try to minimize the use of this because, again, it's only in the setting when you have MDS, or for me, when you have MDS and recurrent infections. The injection itself can cause bone pain. It can be expensive. It doesn't modify your MDS or change its behavior in any way. I only use it in low risk situations because in those patients who are at high risk for transforming, we don't want to increase the risk of stimulating any of those bad actors. So really, most often, if you've received it or it's been discussed, it's typically in the setting of patients who are in the hospital who have a significant infection, and it would help speed the duration of the infection. So lenalidomide is that pill chemo that I talked about. Lenalidomide, if you've heard it, is also approved for other things like multiple myeloma, where it's used very commonly. Given in small doses, it can improve your blood level for specific patient population. Typically, it's given for every day for 3 weeks in a row, and then you get 1 week off. Again, if it works, you continue it indefinitely as long as it's working. Then there's this category of immunosuppressive therapies. They're not very common, but I just want to put this language out there so that you've heard them. One is called ATG, one is called cyclosporin, and one is called Campath. Where they've seen the benefit in these patients, it's specifically hypocellular MDS, meaning that you don't see, it's how it looks under the microscope. It's typically younger patients and patients who have something that are HLA-DR15 positive. So now let's transition over to high-risk MDS. So when we talk about high-risk MDS, again, we know that there's a 25 to 30% risk of progression to AML. And so from that standpoint, the only potential cure would be something called a bone marrow transplant, where you're replacing your immune system. So if we go back to the flower garden analogy, and I'll say it again, just in case anybody joined on late, which is that if your bone marrow is like different types of flowers in a flower garden, that being your immune system, your blood level, and your platelets. When the MDS occurs, your weeds invade your flower garden, preventing your blood counts and your flowers from growing, which is causing all your symptoms. And so if we think of treatment, specifically in high-risk patients, like chemotherapy as pulling out the weeds in your garden, it can do that and it can be effective, but it doesn't get rid of the really deep roots. And so think of the transplant as replacing the soil. And so by replacing the soil or the immune system, it then would allow the flowers to grow normally without having MDS come back. So all that to say is that we decide when patients are diagnosed with high-risk MDS, whether or not they would tolerate a transplant or not. So because there are a lot, and this isn't a transplant talk, but there are a lot of risks and benefits. I mean, there are a lot of risks in terms of morbidity, mortality, prolonged hospitalizations, infectious complications. You're on many medications. You need a lot of caregiver support. So it's not a walk in the park. So it's something to have an extensive conversation about, or specifically be referred to a transplant center. Typically, if it's based on how fit a patient is, or how, I would say, we less commonly use age now. The approximate cutoff, I would say, is about 70, but as we all know, there are many 60-year-olds who have a lot of medical problems who we consider unfit, and there are some 75-year-olds who are very fit and are just as healthy as, say, a 60-year-old. So I'd say age is less important now, although it is a consideration, but it's really whether or not your physician and the transplant team thinks you can tolerate it. So if you're high risk and you're trying to go to transplant, then the goal is to get that MDS and specifically those leukemia cells under to go away. So to pull the weeds before you go to transplant, because we want that new immune system to have the highest likelihood of success as possible. In general, when we think about high-risk treatment for patients who don't want to do chemotherapy or won't tolerate chemotherapy, you can just get blood transfusions and platelet transfusions and chelation support if needed, and that improves their quality of life for some period of time. The commonly used, I would say the most commonly used treatments are hypomethylating agents, both azacitidine, decitabine, and now oral decitabine. We have intensive chemotherapy. I have a few slides on why we tend to not use that, especially in older patients, transplant, and then clinical trials. So the cutoffs that I use and that our institution uses is that your transfusion goal is if you have a hemoglobin less than 7 and a platelet count less than 10. We like to try to weigh risk and benefit of blood transfusions themselves because they're not benign in the sense of you're getting additional iron. It's not your own blood. So we feel that these goals are appropriate. Again, I would talk to your specific doctor about what your transfusion goals, because depending on your underlying medical problems, your goals might be slightly different. And then for iron chelation, it's a conversation with your physician about how many blood transfusions you've received and whether or not there's blood indicators that you might need that therapy. They also have their own side effects, mostly GI side effects of nausea and diarrhea. So the hypomethylating agents are a class of medications. The names are azacitidine and decitabine. They're all equally effective, so meaning one isn't better than the other. The duration and how we give them is a little bit different. So azacitidine can be given sub-Q, meaning under the skin, or given through the IV. Whereas decitabine can either be given through an IV or as in a pill formulation. There's pros and cons to both. The sub-Q version is shorter duration. You're going to the infusion center, they give the injection over 10 to 15 minutes, and then you're monitored for a brief period of time, and then you go home. Whereas with an IV, you would have to put an IV in your arm, give the infusion, so it does take longer. Azacitidine is 7 days, decitabine is 5 days. We don't tend to mix and match, so it's either one or the other. So why do we give azacitidine? Well, when they looked at these studies, you can see here on the right that there's a difference in these two curves, the blue curve being, higher horizontally compared to the red curve, meaning that it improved survival. Overall survival, meaning patients were living longer if they received azacitidine versus other standard care treatment options at the time, which included intensive chemotherapy, something called low-dose cytarabine, or just supportive care. This was also seen when we gave decitabine as well, that patients' survival is better. It can take time to work. So in some patients with azacitidine decitabine, you can see some improvement in blood counts in the first few months, but sometimes it can take 4 to 6 months before you see a response. So just to put that in terms of frame of reference, in terms of expectation management. And then the newest, the oral decitabine, what they were able to do with the pill formulation is make it as effective as the IV, but giving it in pill form. I would say it's much easier to use because it's a pill. I would say the downside is it takes longer to start treatment because you have to get insurance approval. It goes through a specialty pharmacy. That pharmacy has to mail the medication to your home usually. And so in patients who need to start treatment more urgently, I would say oral decitabine is not something that I would recommend. But when it was approved, it showed that in general, there was a clinical response, meaning received any sort of benefit in about 60% of patients, and about 20% of patients went into a complete remission. The side effects are similar to the IV and the sub-Q version. We also know that not just azacitidine, but all of the hypomethylating agents, so both decitabine and azacitidine, improve time to transformation and in high-risk MDS. And so that's why we want to treat these patients. And what you see here, these are plots where they took multiple studies that looked at treatment, and they see whether or not there's a benefit in favor of treatment or in favor of doing nothing. And when you see more little boxes or diamonds to the left, you can see here that it favors treatment compared to favoring no treatment. And so even in looking at multiple studies that have been done over a long period of time, they still showed that treating with a hypomethylating agent does help prevent transformation to AML. Now, when we looked at chemotherapy, should we just is more always better? And the answer is no. So when they looked at intensive chemotherapy, you can see that maybe initially the response rate, so CR and CRP stands for complete response, that this number 60 means higher, so more people responded to intensive chemotherapy. But the response duration was about the same. The mortality was higher. There are more complications that cause patients to die from typically side effects. But patients didn't actually live longer when they got intensive chemotherapy. And there's probably multiple reasons behind that. And so for this reason, we tend not to give intensive chemotherapy for the majority of patients who have high-risk disease. And then when we looked at, we say, okay, we only transplant those with high-risk disease. What about the low-risk disease? Do they do better? And the interpretation of these graphs is essentially that if you have low-risk disease, when they did do transplants in those patients, they didn't live longer. So therefore, you're going through all these complications and toxicities to not live longer. So that's why we don't do it. We just do it in high-risk disease. Unfortunately, if you've received a hypomethylating agent and you've progressed, your survival is not very good. And so even any treatment after a hypomethylating agent, we don't have great treatments and they don't work all that well. So one of the new kids on the block is something called venetoclax. This is not FDA approved in MDS, just so you know. The combination of azacitidine and venetoclax is approved in acute myeloid leukemia, so if you transform. However, there are some promising studies that are looking at the combination of azacitidine and venetoclax in patients who have MDS. And so there's a certain subset of patients who do benefit from them. Venetoclax is an oral chemo. It's something called a BCL2 inhibitor. the MDS cells as well as the AML cells express this BCL2 as well as MCL1 and BCLXL. And so this oral chemo can directly target those cells and more effectively cause the cells to die. We call it synergy when given with azacitidine. So the response rate can more than double when given together. But it does have side effects. This is given, so if azacitidine is given for 7 days, the venetoclax overlaps for the first 7 days as well. So you're taking an IV or a sub-Q injection with a pill. And then after your chemo is done, you're continuing it for another 7 days. So it's a total of 14 days of pill chemotherapy, 7 days of IV or sub-Q treatment. And then you get the rest of 2 weeks off of the pills and 3 weeks off of the IV, and then you repeat it. When they did it, it did show that there were more responses. So here you can see that the overall response was about 85%, which is significantly higher than any single agent hypomethylating agent by itself. Most patients responded within about a month, so 1 cycle, and the response was typically 1 year. So again, this is not a cure, but it gives us more time. So when do we do it? Because it causes the counts to go lower for longer, which increases risks of infectious complications and hospitalizations. The main population that I use this combination for is for patients who are going to transplant. So those who are younger or where we're only going to use it for a short period of time until something else can take over. Because again, because the median duration is only about a month, it's not that it significantly can change the course of MDS forever, but it is helpful in the short term. And then there are other novel agents. Some of these have already been approved in AML. They're starting to make their way into MDS. So I put them here so that you're familiar with names. If you have a specific IDH1 or IDH2 mutation, there are drugs like enasidenib or ivosidenib. Since these aren't FDA approved for MDSs or something that you would have to do on a clinical trial. Again, venetoclax is not approved, so it either on trial or depending on your provider. There's something called pevonedistat, which was what looked really promising, but the phase 3 was closed because it didn't reach its primary endpoint. So recently we've had a lot of drugs that have looked promising, but the reason we do larger clinical trials is because we want to make sure that it's still going to be better compared to standard, and that doesn't always happen. I would say the drug that has the most promising activity from an immune-based standpoint, so immunotherapy, is something called magrolimab, which is something called an anti-CD47 antibody. It has some side effects, but it's not, because it's immune-based therapy, it's not chemotherapy. It can typically be done outpatient and not inpatient. And specifically, the patient population that it's been studied the most is in something called a P53 mutation. So that's where it's the most promise. I'm just going to wrap up here with a few resources. So this is the clinical trials website. So clinicaltrials.gov. So is accessible. So it's for all trials within the United States. You can search by state, by condition. There's typically a lot of different options. So narrowing by where you live is often helpful. Or you can also ask your provider to help you navigate that as well. And then again, all these resources. Again, I'd like to say thank you to the AAMDS Foundation, as well as, we have the MDS Foundation, the Leukemia Lymphoma Society, and then NCCN as well. These are all great patient resources. And then MDS Awareness Week, in case you didn't know, is in March. And MDS World Awareness Day is October 25th. So I'll just leave you with this quote by John F. Kennedy, which is, "The greater our knowledge increases, the greater our ignorance unfolds." And I would say we're definitely learning more about MDS, but as we learn more, we learn that things become even more complicated, and how do we navigate that? And so definitely more to come. We're learning about the mutations and how do we treat these specific mutations with different types of drugs. So I'm hopeful, that in the next decade or so that we'll have more treatment options for MDS. So thank you.
Thank you so much, Dr. Lai, for the wonderful presentation. We have some questions online.
Great.
But do we have any questions in the audience to start out, or I can start right online? Okay, our first question, this is in reference to luspatercept.
Mhm.
What is your feeling about administering luspatercept to those who have had strokes previously? What are the side effects? Are they gastrointestinal? And what is the hemoglobin number you would use to stop giving it?
Okay, so in general, when patients' hemoglobin are above 10, is that I don't give that dose. So patients typically have to be kind of in the 8 to 9 range or lower to have a benefit from luspatercept. Right now, I would say the biggest burden is insurance approval. So most companies like to see that they've been on a previous erythroid stimulating agent before then. In terms of, previous side effects and previous comorbidities, I think I would have to understand how long ago the stroke was, how extensive, are there any lasting effects from it? I wouldn't say you would rule it out completely, but I think it's just a more extensive discussion with your provider about what that risk benefit is. There are more risks given if there are more comorbidities. So yeah.
Great, thank you so much. Our next question is, can you be diagnosed or see early signs of MDS through blood test alone, or can it only be diagnosed via bone marrow biopsy?
Yeah, that's a good question. So when the blood counts start to go low and they're only slightly decreased, but again, not in any dangerous range, what I would say is that should trigger an investigation to see if something else is going on. Because relative to other things, MDS isn't that common, I would say it's really important to rule out other things first, nutritional deficiencies, most specifically. And if everything else has been ruled out based on blood tests alone, and there's still a high suspicion for MDS, that's when we would go to a bone marrow biopsy. So we don't need to jump to a bone marrow biopsy right away. We'll do blood tests first before we move on.
Thank you. Any questions in the room? We're good. Okay. Our next question online is, how many millimeters is the average thickness of the cortical plate in the hip when performing a bone marrow aspirate?
How many? Okay. So the needle, the amount of, let me tell you this, the amount of bone that we take is typically more than 1 centimeter, but less than 3 centimeters. And if we remember that an inch is 2.54 centimeters. So we're taking less than an inch of material from the hip. The bone does grow back eventually. It's a slow process. But this procedure is done the majority of the time in an outpatient clinic with local lidocaine, and if performed by somebody who does them frequently, typically can be a very simple and straightforward procedure.
Great. Thank you. And we have a question in the room. Go ahead, Ron.
To make a bone marrow biopsy less painful, have you considered virtual reality?
Oh, that's a good question. Everybody does it differently. When I do my marrows, I typically let the patient have a music preference of choice, so that they can listen to music. And then depends on the patient on whether or not they like to be talked through the procedure or not. So what's interesting is that there are only pain receptors on the surface of the bone. And so that's why we give topical lidocaine. But if you numb the surface appropriately, once you get past the surface and you're past the cortex, it should just feel, in an ideal situation, I recognize there's a lot of situations here, but it should feel like pressure and not pain when done appropriately. But it's a good idea to do virtual reality. It'd be hard if you're laying face down, but maybe we can kind of like Google Glass or some sort of goggles.
Thank you. Our next question is, what is the average survival rate in terms of years after a bone marrow biopsy for an MDS patient?
You mean a bone marrow transplant? Do I mean,
I'm sorry, a bone marrow transplant. I'm sorry. Yes.
That's okay. So it all depends on what mutations were present prior. And if you do have those aggressive blast cells in the marrow and how many of them there were, and if they've all gone away. So ideally we want them to all go away before transplant. In general, when I give numbers, it's after transplant, about half the patients can be cured from their disease. And then the other half either have complications or can die from their disease as well. Depending on their age, there's also the rule of thirds too, where maybe it's about so it really depends. I'd say you'd have to individualize it to the patient.
Thank you. Do you foresee the future of MDS treatment to be combination therapies?
Yes. Ideally, what I say is that treatment in general is about three things. So it's about combination, it's about timing. So what drugs we use, when do we start, and then how do we sequence the drugs, right? Because for most, if you're not going to transplant, the treatments are putting the disease into remission or improving quality of life. And so as patients are living longer, I think we just have to be smart about which drugs we use and when we use them, just to maximize all the treatment options.
Thank you. Do we know why hypomethylating agents fail patients?
What happens is that the mutation, you get more mutations typically, and that the MDS becomes smarter than the drug. I mean, the drug does the same thing over and over again, but if the MDS becomes smarter, then it's going to outsmart the treatment.
Thank you. This patient is doing well on Dacogen. They'd like to know if at any point in time treatment fails them, should they consider Inqovi, or would there be another combination therapy that would be better?
Oh, so Inqovi and Dacogen work the exact same way. They're just given differently. So I wouldn't switch from one to the other. Occasionally, patients have switched from, decitabine to azacitidine and azacitidine to decitabine, and that can work. It's not the majority of the time, but I would say other things would be, the first thing would be a clinical trial. Sometimes at that point, you can rescue a patient with adding some venetoclax in. And then depending on the mutation specific to that patient, there might be another oral option available.
Okay, thank you. This comes from a newly diagnosed patient who is getting ready to decide on treatment. How do you decide between using Vidaza or Dacogen?
So they're really, in terms of their effectiveness, they're the exact same. So part of it depends on how far other factors. So how far do you live from the infusion center? Because azacitidine is 7 days and Dacogen is 5 days. Whether or not you're going to do sub-Q versus IV. If you really don't want to, if you have trouble getting an IV, or if say you don't want a PICC line, then the sub-Q version is easier because it's more straightforward and less time in the infusion center. I would say anecdotally, and my colleagues have seen this as well, is that in older patients with a lot of comorbidities, we tend to see more infectious complications with decitabine compared to azacitidine. So I would say azacitidine is probably more commonly used than decitabine, at least in the practices that I have been so far. But it's one is not better than the other, is a take-home message.
Thank you. And there was a question here about the MDS score. They wanted to know about a slide that
sure.
you had. If you could show one more time the MDS scoring system.
Oh,
And
sure.
maybe speak about that again.
So this, I believe it's this score. So essentially we take into consideration, so your CBC, which shows your hemoglobin, your platelet count, and your ANC. And then we look at specifically at the bone marrow report, which looks for these blast cells. These are these pre-leukemia cells and what that percent is. And then we look at your cytogenetics and we plug it into this calculator, which you essentially input all these numbers and it calculates your risk score for you. And then similarly with the IPSS-M, you can do the same thing. It's a calculator where you're putting in the same data as the IPSS-R, only you're then taking your next generation sequencing report and looking for those mutations that you have, and then looking this, I wasn't able to put the whole list down, but looking to see if you have any of those mutations, and then you would just click mutated or not, and it gives you a different score.
Thank you. Is MDS more common in men or women?
I would say at least when I've seen it, it's slightly higher in men, but I wouldn't say it's significant.
Thank you. And we have another question regarding transplant. Instead of using hypomethylating agent, should a MDS patient consider just going directly to transplant?
Oh, that's a good question. So in a patient who doesn't have a lot of blasts, or if their blasts are, 0 to less than, let's call it less than 5%, or if they have no blasts, but just have high risk MDS, then yes, you can just go straight to transplant and avoid having to undergo treatment prior. In some situations, it depends on what else is going on. If there's, some fibrosis, or if it's an overlap syndrome, like an MDS MPN overlap, which we didn't get into, sometimes priming the bone marrow with 2 to 4 cycles of a hypomethylating agent can be helpful. So it's really dependent on the patient in terms of what is best to optimize them prior to transplant.
Thank you. This question says, my wife is an MDS patient and looks like her disease is turning into AML. They're aggressively going to be treating. If her blasts come below the AML threshold, is she no longer considered an AML patient?
Oh, so as I mentioned, there's these new guidelines, WHO and ICC, and essentially the lines are becoming blurry. For historical context, we used to also have, the criteria for AML used to be in the 80s was 30%. So if you saw 30% of those blasts or leukemia cells, we call it AML, and before that was MDS. And then we realized that that number wasn't, so we saw that 20% wasn't any different than 30%. So then the cutoff changed to less than 20%. Now there's this category called MDS/AML for patients who have 10 to 19% blasts, which we know those patients are on their way to becoming AML. So I would say it's probably a combination of the percent blasts and their mutations and the goals in terms of whether or not you would then try to be more aggressive about treatment. So switching to azacitidine venetoclax or adding the venetoclax to again get them ready for transplant.
Thank you. And this question is low risk AML really low risk, or is it just MDS that hasn't transformed to AML?
Oh, that's a good question. So I think, so in AML with the risk groups, we call them favorable, and there's no favorable. I think it's, to call something favorable when you have cancer is kind of an oxymoron, but relatively, they're different. The short answers are different. You have to have the diagnosis of either MDS and get a risk group of, low to high, that 5-point scale, or if you're AML, then it's a 3-point scale of favorable, intermediate, or high. So their favorable AML is different from MDS.
Thank you. And this question comes back from the patient who was asking about Vidasa and Dacogen. They want to know, Inqovi was not presented as an option. Should they be asking about that?
So it could be if the patient needs to start treatment sooner, then that wasn't presented. Maybe that physician's not aware of it. So I think it's fine to bring up. If you start, I have had patients where I have wanted to start them sooner. And then at some point in the future, once they're responding and doing well, you can then switch to Inqovi. What we don't do is switch in between cycles. So you would never do, 3 days of AZA and then switch in the middle of the cycle. But if you do a full cycle, and also when you start a full cycle, if you say you're going to do it IV, that whole cycle has to be IV. And say you want to switch to sub-Q, you wouldn't switch till the subsequent month. But there's no reason why it couldn't be discussed and potentially, especially if you go on decitabine or Dacogen, you could switch to Inqovi in the future.
Thank you. This is regards into luspatercept. How long should a patient stay on luspatercept before they would see a response? And when is it time to get off of luspatercept?
Yeah. I mean, when it works, you keep on it and you keep on it for as long as it's working. I've seen some people respond, as early as after, 1 or 2 injections. So that's 3 to 6 weeks. But then otherwise it can take longer. It can, sometimes even take 3 to 4 months.
Great. Well, thank you so much, Dr. Lai, for sharing your time and your expertise with all of us. If you'd like to watch this session again at a later time, it will be available on the conference platform within the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, or submit your question to our Facebook page. If you're watching online, please do take a few minutes to complete the online survey. Your input is important to us and helps us plan our future programming. You'll also be able to visit the exhibit hall and chat with our conference sponsors. Our next session will begin at 1:15 Central Time. So we're going to take time. We're going to enjoy lunch. If you're online, please take time to chat with others and have lunch in the discussion rooms. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to help you and your family, as we've done for the past 39 years. This concludes our session. Thank you.